Good afternoon, everyone. Let me introduce my PhD thesis topic, which is Psychological Aspects of Health Promotion and Disease Prevention. My name is Zsófia Németh. I'm a psychologist, and I'm working at the Institute of Pancreatic Diseases at Semmelweis University, Budapest. My supervisors are Andrea Szentesi and Péter Hegyi, and my scientific methodology supervisor is Jimmy Lee. My vision is an evidence-based healthcare system that bridges mental and physical health, promoting the well-being of individuals and communities. And my mission is to promote psychological research for better patient care and explore the potential of psychological interventions. I have 3 ongoing projects to achieve my vision. My first project is connected to eating disorders and gastrointestinal disease, and it will be a systematic review and meta-analysis. The second project will be a protocol for a randomized controlled trial in a topic of diabetes prevention, and my last topic will be a database analysis in the topic of social support and health-promoting behaviors. So, my first topic is investigating the prevalence of gastrointestinal disease among patients with eating disorders. Eating disorders are psychiatric disorders with the highest mortality rate. In the general population, the prevalence is 8%, but in gastroenterology practice, the prevalence is higher. We know that there's a bidirectional relationship between GI disorders and eating disorders. Eating disorders can cause GI symptoms, and GI disorders can lead to disordered eating habits and different kinds of eating disorders. And why is it a problem? Because eating disorders patients usually receive a late diagnosis, and because of this, 90% of them remain untreated, and up to half of the patients never achieve recovery. And because of this, our aim is to investigate the prevalence of GI disease among patients with eating disorders. The clinical question is, what is the prevalence of GI disease among patients with eating disorders? Our hypothesis suggests that there is a high prevalence of GI disease among patients with eating disorders, and the clinical implication is, for prevalent GI disorders, psychologists can assess for treatment. We created the search key with 2 domains. The first domain refers to eating disorders, and the second one refers to gastrointestinal disease. We conducted the systematic search last year, November, in 3 big databases. We have the 3 key articles with the same condition and same population, and all of the key articles support our hypothesis. We had more than 12,000 articles, but after the duplicate removal and after the selection, we included 93 articles, and during the citation and reference chaser process, we included 41 more articles. So we finished the full text selection this year, January, and now we are working on the data extraction, and I hope we can finish it soon. My second project is investigating diabetes preventive lifestyle intervention after pancreatitis. Acute pancreatitis goes with high mortality rates, and the incidence of the disease is growing. Acute pancreatitis and diabetes have a connection. Now we know that up to 40% of the patients after acute pancreatitis will develop post-pancreatic diabetes mellitus, which is connected to the higher severity and higher mortality rates of acute pancreatitis, and it's also connected to the recurrence of the disease. The problem is that patients after acute pancreatitis are a high-risk population for diabetes, but this knowledge is totally missing from the guideline. There's no established protocol, and there's no guideline for this patient. And because of this, our aim is to determine the best lifestyle intervention to prevent diabetes after acute pancreatitis. We have 2 clinical questions. First of all, are complex lifestyle intervention an effective way of preventing diabetes after acute pancreatitis? And after, we would like to check what kind of resource should the healthcare system provide for this complex lifestyle intervention. We would like to include post-acute pancreatitis patients without diabetes, and we would like to create 4 different kind of intervention for them. And our hypothesis suggests that complex lifestyle intervention is the most effective way of preventing diabetes after acute pancreatitis. And the clinical implication is if we are able to prevent diabetes, we can reduce several health complications, and we can improve quality of life and overall life expectancy. We would like to create 4 different kind of intervention group. The first group would receive intervention from a multidisciplinary team, from a doctor, dietitian, psychotherapist, and a psychologist as well. The second group would receive intervention from 1 expert of the field. The third group would receive an information booklet, and the fourth group would receive the standard care. And our primary outcome will be development of diabetes mellitus, and we will measure the level of hemoglobin A1C. And now let me tell some words about my third topic, which is investigating the effect of social support on health-promoting behaviors among European citizens. In Europe, the prevalence of chronic disease is very high, and usually lifestyle risk factors are standing in the background of this disease. We know that health-promoting behaviors can decrease the lifestyle risk factors and can decrease the prevalence of chronic disease. But the problem is that this kind of behaviors are very, very difficult to change. We have data that social support can be one of the factors which can influence these behaviors. So now our aim is to investigate the role of social support on health-promoting behaviors. We would like to examine European citizens, and our clinical question is that does social support influence health-promoting behaviors such as physical activity, dietary habits, obesity, smoking, alcohol consumption, and sleeping habits? And if we are right, and social support can influence these kind of behaviors, we can promote social support. We can involve family members, we can create family group, therapy group for these patients, and in this way we can promote these health-promoting behaviors and decrease the prevalence of chronic disease. So I have this 3 ongoing project. I hope I can finish my first one, which is connected to eating disorders and gastrointestinal disease this year, and I hope to finish my protocol next year and finish my database analysis in 2027. And I would like to close my presentation with the words of the World Mental Health Day, that remember, it's okay not to be okay, you can heal your mind and shine your light. Thank you for your attention.
Thank you very much. Any question from the audience?
Regarding your second project, what your personal assumptions? The more is the better, or which arm will have the best result?
I'm really curious about this, and I think that the multidisciplinary team will be the best solution. And in my experience, when I'm able to work with a dietitian and with a physiotherapist, we can have really good examples that this teamwork can work in real life really well.
It was a nice presentation. I just want to ask that for your first project, that is there any special subpopulations for this mental disorders thing that you want to examine thoroughly, because there are some special for age or gender or something like that?
Okay, so I will examine patients with eating disorders, but we have different kind of eating disorders. For example, anorexia nervosa, bulimia nervosa, and binge eating disorders. And these disorders emerge in different time during the the patient's life. For example, anorexia nervosa usually emerge during the age between 12 and 15, and bulimia usually starts in the early adulthood, and binge eating can start later. So, of course, I think it's important to create groups, subgroups, and do the analysis in them separately.
Thank you.